We're back with part 3 of the emergency nursing section, chapter 72, and we're going to go with a continuation of frostbite with the environmental emergencies of hypothermia. Internal core temperature of 35 Celsius or less is considered hypothermia. It usually affects older adults, infants, people with concurrent illnesses, and homeless people, and trauma victims because their regulatory senses have been put at risk. Alcohol ingestion can increase the susceptibility. So we were talking about homeless people on the streets. A lot of times are involved in alcohol intoxication, so they tend to get hypothermic because they're out in the elements. Hypothermia may be seen in frostbite, like we were talking about. In treatment of hypothermia takes precedence as far as emergency situations and triaging patients. Physiological changes in all the organ systems can happen, just like with a heat stroke. Being cold can also damage kidneys or vital organs throughout the body. Again, we're going to continuously monitor this type of patient. So monitoring them is the management of hypothermia is the same thing. Airway, breathing, circulation. Remove any wet clothing if it was something where they were exposed to cold water. If it was rain, snow, we need to rewarm them. Just like we would cool down in heat stroke, we need to rewarm them. Supportive care as far as whether or not they're in pain. Again, medications and things like that. Rewarming involves active core rewarming, so cardiopulmonary bypass. If they're very severely hypothermic, cardiopulmonary bypass machines, warming fluid, fluid that is kept in a warmer in the medication room will be the kind of fluid that would be given. Warm humidified oxygen. I haven't seen that very often, but it's an option. Warm peritoneal lavage. That again, I have not seen. It may happen if there's other things going on with a patient. Passive external rewarming involves warming blankets and over-the-bed heaters, and we were talking about that warming blanket before the bear hugger. Cold blood returning from the extremities has a high level of lactic acid and can cause potential cardiac dysrhythmias and electrolyte disturbances. So keep that in mind when you're rewarming the patient, that there could be, they need to be on the monitor, their vital signs being monitored very closely, very quickly, usually every 5 minutes, and depending on the situation. So very closely monitoring how they recover from this situation. So at this point, your text goes on to talk about non-fatal drowning, decompression sickness, and those kind of things. So please make sure you read your readings. So now we're going to move on to poisoning. Poison is any substance that's ingested, inhaled, absorbed, applied to the skin, produced by the body, meaning chemical reactions within the body, and a relatively small amounts of injures the body by its chemical action. So it can be an animal bite, it can be exposure to some kind of chemical like bleach or a chemical that you work with, a gas that you're working around, inhaled, again absorbed. It can be a tick or any kind of thing like that. We're going to go into all of those things. Treatment goals are to remove or inactivate the poison before it's absorbed. Provide supportive care in maintaining the vital organ systems, just like we talked about with hypothermia and hyperthermia. Pain can be involved in the process, so we need to make sure that the patient's comfortable. Administering specific antidotes for whichever poison the patient has been exposed to is really important. Implementing treatment to hasten the elimination of the poison. So we really need to focus on getting the poison out of the system. So managing these types of patients, again, you're going to see managing the airway, breathing, circulation, monitoring vital signs. You're going to see a lot of this is pretty repetitive. for these type of injuries and problems in emergency situations. Obtaining lab specimens to find out how the body is reacting to poisons, determining what, when, where, and how much of the substance was ingested. This is important because you have to call poison control. As the nurse, you'll have to be calling poison control, and they'll want all those details. Poison control has all the information that they need and steps to care for patients that are exposed to certain toxins. So they need to be, one, notified because the government keeps track of poisonings and things like that. And then they want to know what the poison was, when did it happen, how long were they exposed, signs and symptoms of poisoning and tissue damage. You need to know the health history and age and weight of the patient so that you can treat them properly with the right antidotes. So some of the measures that we use in the emergency room to remove toxin or decrease its absorption are emetics, medications that actually make you vomit. I really haven't seen much of that. Gastric lavage is more of what I've seen, depending on the exposure, whether it was an ingested on purpose or ingested forcibly, depending on the issue. The gastric lavage is actually a very quick way to empty the stomach, as long as it was within 30 minutes to an hour, usually. Activated charcoal, I've seen a lot in the emergency room for patients that purposely tried to overdose on medications or accidentally overdosed on medications because they were in pain. For instance, if they took Tylenol every 2 hours because they hurt so bad and nothing was working and they just kept taking it and taking it, that can be something that's used. Activated charcoal is in a liquid form. You have to really shake it up and warm it up, and the patient has to actually drink it down to deactivate the chemicals. So activated charcoal can deactivate a chemical within the stomach. Cathartic, when appropriate, administration of specific agonists as clearly as possible, as early as possible, such as antivenin. We're going to get into that. Other measures may include diuresis, dialysis, hemoperfusion. We'll talk more about Tylenol levels in the blood system. Usually if it's gone past a certain point where you can't lavage the patient, we'll get more into how it binds to the bloodstream, but there's a drug that we can give as an antidote for that, and it actually binds to the molecule in the bloodstream and protects the kidneys and liver from damage because of overdose of Tylenol. Corrosive agents such as acids, alkalines, cause destruction of the tissue by contact. So if you're working on a car and a car battery contents gets in on your skin, if you're working on a piece of equipment that involves batteries and the batteries are corroded inside, the chemical can get on your skin that way. If it's ingested, you don't want to induce vomiting because it can corrode the entire esophagus and cause destruction of esophageal tissue. Management of a patient that has carbon monoxide poisoning is whether it's intentional or non-intentional. Intentional would be attempted suicide. You've heard the story of a car being in a garage and the garage door closed and the person turns the car on and intentionally breathes in carbon monoxide. There's other times where people are exposed in a room where carbon monoxide is inadvertently being pumped in for whatever reason. That can happen. And what happens in inhaled carbon monoxide binds to the hemoglobin, and as it's hard to say, carboxyhemoglobin. Carboxyhemoglobin does not transport oxygen. So you are essentially depriving your cells of oxygen with this. So symptoms would include usually neurological. People's skin color is not a reliable sign. Some people say, oh, if you're carbon monoxide poison, then you look blue. That's not so much a reliable sign. The pulse ox is not going to be valid because it's not able to read what what's going on under the skin. So treatment is getting fresh air immediately, getting them out of the situation. Usually if it is something like we talked about a minute ago about the intentional ingestion, paramedics would get there and immediately take the patient out into the open air. CPR if the patient's already coding, systems are shutting down, administer 100% oxygen, non-rebreather, or if they can get to a facility where they can do a hyperbaric pressure chamber, that is the most ideal for getting rid of that carboxyhemoglobin. Monitoring, of course, closely. So the emergency management of the patient with chemical burns is similar to what we were talking about. The severity of the injury depends on the mechanism of action of the substance and the penetrating strength and concentration, the amount of the skin exposed, and the amount of time that the area has been exposed to the agent. Immediately flushing the skin with running water from a shower, a hose, faucet. A lot of hospitals have those sinks with the eye wash. That would be if the chemical got in the eye, the face. It can also be used for anything else if you were exposed to that. But the patient being exposed to a chemical, it needs to be washed off immediately. Lye or white phosphorus should be brushed off this dry skin, because if it gets wet, it actually activates the corrosive properties of lye. So if it's dry and on the skin, just scrape it off as much as possible, wipe it off with a dry towel, and get it off the skin. Protect healthcare personnel from the substance. So it's really important if you have a patient that has been exposed to a chemical, that you don't happen to become the secondary person that's exposed. So really protecting healthcare workers from getting the or even EMS from getting the stuff on them as well. You got to determine what kind of substance it is. If it's unknown, investigating what type of substance it could be is really important. Some may require prolonged flushing or irrigation. It's not just enough to do a quick rinse, so they'll need to be overly irrigated. Follow-up care includes the re-examination at a 24-hour period. So this is where poison control would come in. They usually follow up within 24 hours again, and then 3 days later to find out what happened to the patient, sometimes even a week later. So they have a system on how they're supposed to follow up with that. Moving along with poisoning, we're talking about food poisoning at this point. I think a lot of us have had an experience or two where we ate something bad and it just was awful. I had an episode one time where the last thing I had was raspberry chocolate. And I tell you what, to this day, I cannot eat raspberry flavored chocolate. But it's a sudden onset illness caused by ingestion of contaminated food or drink. That could be contaminated with either a chemical, or it could be bacterial growth from food that's been left out at room temperature for too long. Again, we see the ABCs, supportive measures. Food poisoning such as botulism or fish poisoning may result in respiratory paralysis and death because it affects the diaphragm and muscular tissue. So that is a real emergency. So that's why it's really important to get a good health history on the patient to find out whether this was the type of exposure. Determination of the food poisoning, meaning like where did it happen? What was the last thing you ate? What was it at home? Was it at a restaurant? If so, which restaurant? They need to be informed of these things. Treat with fluid and electrolytes. Try to treat the food poisoning with replacement of fluids and electrolytes like potassium, magnesium, that kind of thing, because typically a patient will be either having diarrhea or nausea, vomiting, and we talk about that in the fluid electrolyte balance portion of the lecture process. So it's the same thing that we've talked about before. The high priority is to control nausea and vomiting because of the losing of potassium from the hydrochloric acid in our stomach. Our body shifts potassium into the bloodstream, and then we keep losing it if we keep vomiting. So the more you vomit, the worse it gets. So what I always tell people is Do not eat and drink if you have vomited within the last hour. You give your stomach a break. Do not eat or drink anything. If it's to the point where you've been throwing up or the patient has been throwing up for over a 24-hour period, mild food poisoning a person can usually manage at home, but usually they end up coming to the emergency room if it's been prolonged and they just can't keep anything down, and that can be a dangerous situation. Clear liquid diet and progression of the diet after the nausea vomiting subsides, and that means absolutely subsides. That means the patient took a drink of water and all of a sudden they feel nauseous. Do not feed them. Do not give them anything to drink for an hour. Apply antiemetics and watch the patient closely. So the management of a patient with a drug overdose, we brushed on that a little bit earlier with the ingestion of a chemical such as Tylenol or any kind of medication. Clinical manifestations can vary with the medication. So, for instance, if it's a benzodiazepine, lorazepam, Xanax, that kind of thing, you're going to have very heavy CNS depression. Patients can be unconscious. Heroin overdoses have a similar effect, but when it's an ingestion, Table 72.1 identifies the common abused drugs. And we'll go over. Some of them are cocaine. I know that sounds odd that someone would ingest cocaine, but commonly the thing I've seen, I actually had a patient that did this. A patient actually swallowed a latex bubble full of cocaine to hide it from the police. He ended up having a massive heart attack and dying. But had he gotten to the hospital soon enough, we would have been able to get that bag out of there, out of the stomach, where it wouldn't have exploded and caused him to die. So other drugs are opiates, barbiturates, inhalants, such as huffing, and that stuff can get into the system. Amphetamines, hallucinogenics, LSD, that kind of thing. Aspirin poisoning or salicylate, like NSAIDs, people taking, like I said, Tylenol too much, or ibuprofen, the salicylates too much because they're in a lot of pain. It can be intentional or non-intentional. Tricyclic antidepressants are in there. So the treatment goals are to support the respiratory and cardiovascular function. Again, just like anything else in it, that chemical that you're exposed to, if ingested and it's causing CNS depression and respiratory depression, you're going to follow the ABCs again. Enhance the clearance of the agent. That means in like barbiturates, there's antidotes for that. Opiates, there's Narcan given IV to reduce the effects of that. Provide safety for the patient as well. Usually the patient that's obtended from ingesting a medication that has already started affecting them, they can be at high risk for injury to fall, to occlude their airway, that kind of thing. So again, we're talking about safety and looking at the ABCs every time. IV drug users are at high risk for HIV infection, hepatitis, and tetanus infection because they don't tend to be cognizantly aware of the effects of dirty needles and that kind of thing, and they tend to not care either. And this is another opportunity when you have a patient like this. We really have to stay clear of any kind of judgment for the patient because this is their disease. If a person is going through something and they ingest something on purpose, or they have a heroin overdose, or these kind of things, it's what they're going through, and shaming them and guilting them is definitely not productive to their recovery. So I suggest the sensitivity for these type of patients. You always want to be open arms and non-judgmental and just help them through this crisis. That tends to happen a lot in healthcare where there's a non-sensitivity to someone in this category. They're really suffering, especially heroin addicts. What you need to understand physiologically, what's happening with a heroin addict is that the receptors in the brain have actually replaced what normally would be our sense of needing to eat and provide ourselves with nutrients. Heroin now is the drug that the body craves. Instead of food, instead of getting shelter, instead of protecting yourself, heroin becomes everything to that person. So again, like I said, we have to understand that is a physiological thing that's happened to them, and it's not necessarily a choice at that point. When a patient has to detox from heroin, it's a horrible, horrible detox process. So it's same with alcohol, but heroin, I would have to say, is a level up on that, and it's a very big struggle for them. So please try to be sensitive to that kind of thing and understand the physiological aspects of a heroin addict and their overdosing periods. So that leads us back into the management of patients with substance abuse. Again, we talk about alcohol poisoning or acute alcohol intoxication. I got to say that in the emergency room, there's been, that was a lot of the patients that came in the evening, especially early morning, 1, 2 in the morning. It would happen during the day as well, but mostly at night. It usually affects every organ system. It can also result in death. So I don't know if any of you have seen those videos where there's an intoxicated person on the sidewalk, and they're so intoxicated that they don't even see people talking to them. So people will try to nudge them, nothing happens. You really have to be concerned about them. I think that we, again, judge too quickly. This is their mental illness that's happening, and we need to be sensitive to that. You're going to see the same alcoholic come into the ER over and over and over, and it is not our place to judge what's happening to them. It's our place as nurses to help them to get to a place where they can recover. Now, whether or not that happens still is the patient choice, but we still have to treat them with dignity and make sure that they get the resources that they need. Whether or not they do anything with it is not our control. We need to maintain an airway, especially if the person is highly intoxicated and they can't even breathe. They're doing the snoring respirations or almost apneic episodes. It's the same thing we talked about earlier, putting the oral airway in until the patient can actually come out of the intoxication by providing IV fluids and things like that. Same thing. Rule out other potential causes for the behaviors before it's assumed that the patient is intoxicated. So that would involve like drug screening, urine samples, and things like that. So we need to get blood alcohol levels. If it comes back that there's no alcohol in their system, then something else has caused it, and we need to find out what happened. Again, we went along with the non-judgmental thing. We might need sedation on a patient that is awake and being obnoxiously drunk, belligerent, cursing at people. Again, it goes back to the safety aspect of emergency nursing and protecting yourself. If the person is out of control and being combative and that kind of thing because they're intoxicated, then we need to put them in a safe area so they don't hurt themselves and they don't hurt staff. Examine for withdrawal delirium. I think we learned this from second semester. Usually starts between 48 to 72 hours after the last drink was ingested. Now, that's not a blanket statement for everybody, because some people will go into the alcohol delirium withdrawal symptoms earlier. So not everybody is a cookie cutter on that aspect, but typically it's 48 to 72 hours. And again, we need to prevent injury from any kind of seizure activity. So typically with the alcohol withdrawal people, we put seizure pads on the stretchers. A lot of times alcoholic patients or patients that ingested alcohol will be in the ER for most of their time and don't get admitted to the hospital because of other things that are admitted, so other injuries or illnesses, and they take priority sometimes. So you might be sitting on a patient in the ER all night long, and then in the morning the patient wakes up from their alcohol intoxication and they are fine and they say they want to go home, and then they get discharged from the ER. Another thing that the emergency room deals with a lot is sexual assault victims that come in, and management goals are to provide them support, reduce their emotional trauma, and gather available evidence and for possible legal proceedings. And this is where you have to be really sensitive not to force anything on them. They've already been through something very traumatic. So getting a good health history, good history of what happened, involving law enforcement and having the forensic nursing come and do an exam. Nurses may be SANE certified, and that is a organization of forensic nurses. It's called the Sexual Assault Nurse Examiner certified, and there's a company in Arizona that specializes in coming to emergency rooms to perform a forensics exam on a sexual assault victim. The name of the company is really leaving me right now, but we have many of those. Physical examination, specimen collection is super important and usually done by the forensic nurse. Treating consequences, meaning providing pregnancy prevention and sexually transmitted infection prevention and medications. Encouraging the patient to get follow-up care, whether it's medical or counseling, is very important as well. A lot of you have been hearing the word human trafficking. It's a serious thing that's going on all over the world. It's the most growing area of criminal activity in the world, I think, a lot because of the internet and a lot because of, well, I could say the internet. It's defined as the use of force, fraud, coercion for the purpose of subjection into involuntary servitude. Now, this is not the same thing as voluntary prostitution. That can tend to be a person's choice to do. Human trafficking is specific for a person being controlled. Typically, it's going to be a younger population of women and men or boys, and they're being put out to provide sexual services for people. The data shows 20 million people are trafficked, with at least 17,000 in the United States. These people have limited access to health care. So what we need to look for in the emergency room are signs and symptoms that someone may be a victim of human trafficking. They may present with an injury accompanied by a boyfriend or a travel partner that won't leave their side. Somehow you have to, if you get that gut feeling that there's something going on that's just not right, then you need to try to get that patient alone to be able to ask them questions. History of chronic runaway, homelessness, self-mutilation. Those can be signs that someone's in a situation where they just feel like they can't get out of, and so they resort to self-mutilation or self-harm. Common behaviors are cowering, frightening, agitated, deferring the persons accompanying with them, making them talk for them. Common complaints or injuries are like poor healing, wounds, abdominal pain, dizziness, vague symptoms of headache, rashes, sores. They also may demonstrate addiction behaviors like heroin addiction, methamphetamines, panic attacks, impulse control, hostility, suicidal ideations because they just want to get out of the situation. So we have to be vigilant as ER nurses to try to pick up on things like that so that we can try to provide people with resources if this is what we suspect is going on. So again, going back to managing this type of human trafficking would be to offer an opportunity for the patient to speak alone, like I said, without the companion. Use targeted, appropriate questions. Are you in control of your own money? Are you able to go home or come and go as you please? Who is this person that's accompanying you? How are they related? They may decline assistance because they're too scared to get help, and we really can't go out of our scope to force any kind of help on these people. You can give them the National Human Trafficking Hotline. There's a hotline that's all set up for that. Last but not least, the overactive patient. The overactive is a nice word for saying the violent or belligerent patient that acts out. please, please, please remember the definition of an overactive patient or a violent behavior underactive depressed patient and suicidal patient is an underlying cause. They have something going on. It's not just your typical attitude against the world. It's not necessarily antisocial behavior. There can often be something that's underlying that's going on with them, and we really have to be sensitive to those things. Management involves maintaining the safety of all the persons involved and gain control of the situation. So we got to let them have as much control as they can have without being, again, safety of the staff. So if the patient is throwing punches and being violent, we have to restrain them, calm them down, make sure they're safe and they're not going to hurt themselves, they're not restrained improperly, that kind of thing, where they can actually get injured. It's a very hard teeter-totter to do on a patient that's violent because, for one, as staff, you're afraid for your life sometimes, but also we have to follow safety measures in getting security involved, and security personnel are usually trained in how to deal with violent behavioral patients. So let them do it, and only get involved if you feel like you are helping the situation and not going to be in a situation where you end up getting injured more. So again, safety, safety, safety. Determine if the patient's at risk for injuring themselves, whether or not they have to be on surveillance or being watched under suicide watch, that kind of thing. Maintain the person's self-esteem while providing care. Again, this can be very difficult sometimes because people can be really belligerent and they're cussing at you and they're telling you what a horrible person you are and they're calling you names, but usually it has nothing to do with you. And they ended up in the emergency room because either police or the person didn't know where else to go. And we are prepared to deal with patients like that. And we have the resources with counseling and social work and all that kind of thing. Determine if the patient has a psychiatric history or is currently under the care of a therapist. Try to find out if there's any medications that they were supposed to be taking. A lot of times bipolar, schizophrenic patients have a really difficult time when they're not on the medication, that they just want to stop taking it because they want to feel normal. So we also have to take that into consideration, that maybe they're off their medication. Is there a chemical imbalance going on that's maybe a sodium level is too low and maybe they're acting out because something's going on physiologically? We need to do crisis intervention with them, intervention specific to each of the conditions. So again, I can't emphasize enough, take a look at the situation and try to put it in perspective as to what's going on with the patient rather than using any kind of negative judgment against them. And you'll have a much better time in working in emergency. That comes to the end of our PowerPoint today and our video today. So just feel free to review the lecture as many times as you possibly want. They're available to you. Take notes too when you're watching them, and follow along with your readings, and you'll do fine. So we'll see you on lecture day. Thank you very much.